Well, hello, welcome everyone to today's Spinal CSF Leak Canada's webinar. We'll give everyone a moment to join before we get started. Thank you for joining us for this session on navigating pediatric spinal CSF leak, insights into diagnosis and care. My name is Bahari Cloutier, and I'm the founder and chair of the Spinal CSF Leak Canada. And for those of you who are joining us for the first time, Spinal CSF Leak Canada is a national charitable organization dedicated to improving the lives of patients suffering from spinal CSF leak. We work hard to advance this mission through awareness, education, and also supporting research. And this webinar is part of our ongoing efforts to expand knowledge and improve care for patients and families navigating this challenging condition. I'd like to sincerely thank Dr. Mesha Martinez for generously sharing her time and expertise with us today. And I would like to also thank Dr. Paul Kim, who kindly accepted to moderate this session for us. So Dr. Kim, I'll now pass it over to you to introduce our speaker and get us started. Thank you.
Thank you very much, Bahari. Can you hear me okay?
Yes, we can.
Good evening, everyone, if you're on the East Coast or afternoon, I suppose, if you're on the West Coast. My name is Paul Kim. I'm an anaesthetist in background, but I'm currently a chronic pain fellow at the Toronto Western Hospital. I'm quite new to the world of spontaneous intracranial hypotension, and it's a real privilege to moderate this session. But firstly, just want to thank Bahari, the chair and the founder of CSF Leak Canada, and a true force of nature in raising awareness of this fairly new diagnosis, I would say, and driving such a rich educational content, such as this webinar conferences. And now I have the pleasure to introducing our speaker for today, Dr. Mesha Martinez, who I'm sure many of you already know in the audience. So Dr. Martinez is a board-certified pediatric radiologist, neuroradiologist, and a neurointerventionalist. She's an internationally recognized expert and leader in pediatric neurointerventional radiology. She's earned her medical degree from Temple University, followed by some really prestigious training at top-tier institutions, including Johns Hopkins, the Children's Hospital of Philadelphia, and the Icahn School of Medicine at Mount Sinai. So her clinical expertise spans from pediatric stroke, head and neck vascular malformations, intra-arterial chemotherapy for retinoblastoma, intra and extracranial AV shunts, spinal vascular and non-vascular disorders, and CSF pressure disorders. She's widely published, expert in this area, and frequently invited as keynote speaker in national and international stages. But Dr. Martinez served also as an associate professor of radiology at Baylor College of Medicine and as a neurointerventionalist at the Texas Children's Hospital. She's a clinical instructor at the University of Washington School of Medicine and Seattle Children's Hospital. Dr. Martinez is also the founder and the medical director of Clarity, Brain and Spine. This is a leading outpatient neurointerventional practice and it provides specialized care for both pediatric and adult with cerebrovascular, CSF, and spinal disorders. She has received numerous honors and awards, including being named Austin's top doctor this year, in fact, in 2025. So Dr. Martinez will be talking on the topic of navigating pediatric spinal CSF leak, insights into diagnosis and care. So just a quick reminder to all the audience here. So please feel free to post your questions at any time in the Q&A box. Dr. Martinez will try to address them at the end, as many as possible, time permitting, in the last 10 to 15 minutes of the session. It's an absolute honor to have you here, Dr. Martinez. I'll hand it over to you now.
Thank you so much for that wonderful introduction. I'm not sure who you were describing, but maybe it was me. Hi, everyone. My name is Mesha Martinez, and as he already introduced me, I'm going to share my screen, and we're going to have a little bit of fun today, but really just learn about something that is dear to my heart, diagnosing and treating children who suffer from CSF pressure disorders, but more specifically for today, suffering from CSF leak. So I kind of wanted to start off by saying, I think that this diagnosis, getting recognized as an entity in the pediatric population, also in the adult population, and the care of this entity is very difficult for patients, for parents of these patients. There seems to be a lot of categories that we as physicians have been taught in medical school of what CSF is and what disorders are associated with CSF. These are in very tight boxes that not many people stray from. And so it becomes difficult to make the diagnosis when patients don't fit neatly into the box. And so for years and years and years, CSF leaks has been associated with females that are older, 40s to 60s, if you look at the data. And there's a whole bunch of literature that addresses this demographic and this population. But when you start doing your digging and looking at the pediatric population, one begins to wonder, is that an entity in children? Does it impact them the same way? And why hasn't this been a diagnosis that we've been taught that now seems to be becoming more and more of a conversation as each day goes by? And so, one of the things I wanted to remove from my topic was, for my title, was the spinal part. I really am going to be talking about navigating pediatric CSF leak because I don't want us to be in a box when it comes to this diagnosis, treatment, and care. Any child who's leaking CSF from any part of their body can have these symptoms, can have these problems, and the care is similar, which is to fix the leak. All right, so sorry this came out fuzzy, but the background is saying the struggle is real. And this is a common saying that me and my family, we talk about all the time about day-to-day things and life things. But for CSF disorders, and in this topic today, CSF leaks, we have heard on the clinician side, and I have heard on the parent side and the patient side, how often patients are having these very, very, very serious neurological symptoms, and they are going from doctor to doctor, even patients from outside of the United States, patients in Canada, patients in Europe, wherever you are. There's something about having a CSF leak, finding doctors who understand that your symptoms are not going to be typical all the time, getting treatment and follow up, and getting back to life after you suffer from this. So we are all very much aware that the struggle is for real. And that's going to lead me to tell you two stories. One is a story that happened last year where I was out to dinner with a bunch of physicians. And this is a picture of an anesthesiologist. And this may be all you see before you go to sleep for a procedure. Now, how are anesthesiologists important in this story? Well, anesthesiologists are doctors who not only are responsible for putting you to sleep for procedures, but they are oftentimes the doctors who are there to take away pain. They are the doctors who are going to do the blood patching when it comes to the treatment for a CSF leak. And so at this dinner, when I was discussing with a bunch of anesthesiologists about my passion and knowledge and experience about CSF leaks in the pediatric population, they started telling me a little bit about the history of pediatric anesthesiology and the concept of CSF leaks. And although I don't remember all the details of the conversation, I do remember very clearly that it was taught going years back that children just really didn't have the symptoms of spontaneous intracranial hypotension, that kids don't get headaches from the CSF leak, and most of these children will just naturally repair themselves if they do happen to get one, which usually is going to be caused by an operation or a surgery, and they'll get better. There's not much to do. And this is coming from a branch of medicine that plays a huge part in fixing CSF leaks by blood patching. So that's story number one. The second story, I have this picture here where I'm showing you pictures of children who suffer from congenital defects. Did I lose my screen? I hope I did. Can you guys still see my screen?
Yeah, you're good.
Okay, perfect. Okay, I was moving my face out of the way of my screen. Okay, so these were children who are suffering from um, abnormal formation of the calvarium. And it just so happened that the youngest patient that I have treated with a blood patch for CSF leak was a 3-year-old. And he actually suffered from this diagnosis called craniosynostosis. And again, this is the abnormal development of the skull. And it does have a significant association with development of the veins of the skull, as well as the development of the brain and the fluid that cushions the brain, which is the cerebrospinal fluid. So this little guy, he had multiple calvarial skull repairs and ended up developing headaches and papilledema. So what we did was a lumbar puncture for him. And after the lumbar puncture, he started complaining of a different type of headache. Now he's 3, so he wasn't able to say a different type of headache. But the reason why we knew something was different was because now he just wanted to lay in bed and not get up. He's 3 years old and he won't get out of the bed. And he was crying after the lumbar puncture, much to the so much to the point that mom turned back around, came back to the hospital, even though she was going home after the lumbar puncture, and just said he is screaming, he's grabbing his head. Remind you, he's 3. And I turned around and I came right back because he also is starting to vomit and throw up. So he gets admitted, and that's what we noticed. He would not get out of bed. So conversation passes, and the neurosurgery team was very concerned because they thought, we're not sure what's going on. We don't know what it is. Um, why he won't get up out of bed. We're going to do a Bolt monitor. Now, a Bolt monitor is something that we place into the skull to measure the pressures actively. So you can have a Bolt monitor in your head and you can get up and you can lay down and you can move around and it's actively monitoring and measuring the pressures inside your head. So they did this because they didn't understand why this child, after a lumbar puncture with this complex congenital diagnosis, would not get out of bed. Well, I was one of the physicians involved, and I kept telling the neurosurgeons this is because he was high pressure, had a had a lumbar puncture, has developed a CSF leak, and the reason why he won't get out of bed is because he has low pressure. Now, neurosurgery in turn said to me, no, 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 no. I don't believe so. And it goes back to the conversation that I had with the anesthesiologist. Kids don't have CSF leak. Now, the neurosurgeon didn't say that, but she or he will let them remain genderless, really insisted that there was no way that that's what this was going on. So Bolt monitor was placed because he was a complex case. He was 3 years old, and he couldn't really talk about what was going on. And then we noticed that the numbers on the monitor were in the negatives. So after that, when I rounded him on over the weekend, I told mom, I know what's going on. This is the diagnosis. Let's do a blood patch. Literally, he had a blood patch that following Monday. I spoke with mom on Sunday. On Tuesday, he was up and running out of bed with the Bolt monitor sticking from his head and showing that his numbers have returned to normal. So, again, I say this all to say, and I share these stories to say that the struggle is real when it comes to different practitioners understanding that this is a real phenomenon in children. The struggle is real because pediatric patients who are not young adult or young children who cannot communicate clearly will sometimes not be able to say the same things that normally tips us off that it's a CSF leak or something causing spontaneous intracranial hypotension. And so it can be a really difficult diagnosis. And so we're going to rewind back in history a little bit and kind of go through what is the history of CSF leak in the pediatric population. and then talk about what is the history of spontaneous intracranial hypotension in the pediatric population. So if you rewind back, um, years ago, children were diagnosed with CSF leaks. But again, it was always thought to be secondary to birth defects, hydrocephalus, some type of significant trauma like a car accident, or someone hit their head and had skull fractures, something that we, the physicians, did. That's what iatrogenic means, meaning um, we did a surgery and the dura, that's the covering around the head, around the brain, and the covering around the spine that keeps CSF in. It ends up getting cut or nicked, and then there's leakage. And then there's always been an acceptance that children with connective tissue disorders and the diagnosis of Marfan's and Ehlers-Danlos hypermobile types specifically can suffer from CSF leaks as well. But when you look at the literature, it was always these very dramatic diagnoses that physicians would say, yes, on a pathophysiologic basis, I understand that this child can develop a CSF leak. If you fast forward a bit out of the past and get into the last few years or last decade and a half or so, where CSF leaks and CSF fistulas have become more and more of a conversation, and a lot more people are talking about CSF leaks. There's not many papers on pediatric cases, and most of them are case reports, and most of them are having a hard time understanding that children do have headaches that are commonly misdiagnosed as migraines, um, nausea and vomiting associated with these headaches that are going to be diagnosed as GI issues. And if they have a skull-based leak, and like I said, we're going to talk about all leak, um, if their nose is running or their ears are dripping, then they're thinking it's secondary to some type of infection, an ear infection, which is something that children commonly get, or they're thinking it's due to sinusitis. And because we don't do a lot of imaging for sinusitis, um, they're not realizing that this rapid dripping from the nose that mom is reporting about her child when he goes to bend forward could be secondary to a CSF leak. And so there was a paper just published in 2024 that was the first paper on, I think, about 24 patients that talks about using myelography to diagnose patients from a multi-center trial. And then there was another paper back in 2012 by Dr. Shovnik and the Cedars-Sinai group that talks about another 24 patient cohort of looking at spontaneous intracranial hypertension. And again, this is in 2012 in the pediatric population. So even though it's becoming more and more common and more recognized, we still have a long ways to go to understand that children do suffer from CSF leaks. If we're not aware and we don't have the knowledge and we're not expecting it and we're not thinking about it, it's not on our differential diagnosis, then this diagnosis becomes something we're not thinking about and we're not making. And then children go undiagnosed, untreated, and again, eventually they'll get into adulthood where sometimes they'll be diagnosed then, but sometimes they'll just remain chronically symptomatic for life. So if you don't remember anything I say before we start doing our case presentations to learn at the same time, just remember anyone can suffer from a CSF leak, just like adults can. The future of the adults are children first, and it can happen at a very early age. All right, now there's three categories we're going to talk about tonight and three patient cases that I'm going to present, actual cases of mine. I could go on and on and on, but I tried to do this in a very simple fashion that I have identified occurs in the pediatric population. The first patient that we'll see, and this is not an order of frequency or anything like that, is the patient that has been talked about in the literature. 54% of children in that huge case series that Dr. Shovnik and his team did showed that 54% of those 24 children had a connective tissue disorder. So you're going to have patients who have a known connective tissue disorder, and they probably are going to get a quicker diagnosis in the pediatric population because there is a known association between connective tissue and CSF leak. The second patient that I commonly see is the patient who doesn't have a history of anything, but presents with a tear in the dura that's causing CSF leak and symptoms. And what I find is that these symptoms are very similar to symptoms that adults can have. I want to lay down, I don't want to play. I'm extremely fatigued and I'm tired and I'm sleeping a lot because they want to lay down. I have this headache when I go to sit up, et cetera, et cetera, et cetera. But we'll talk about a little bit about the different causes of this tear in the dura for children in a bit. And then the last one, which is a very dear topic close to my heart, is these patients who actually have underlying idiopathic intracranial hypertension due to increased CSF production that eventually causes intermittent or ongoing CSF leaks. So we'll start off with case number one. This patient was a patient of mine a few years back. He's actually, well, it's been a while now because he just graduated from high school and sent me an invitation in the mail. But he was 13 years old when I met him. He had a history of Marfan's. His mom was diagnosed with Marfan's. His sister had Marfan's. It was pretty prominent in their family. And as a family, they knew the medical system in and out because they were constantly having checkups for their heart, for their valves. They, interestingly, would have multiple dislocations that caused them to end up in the hospital in order to get sorted out and other just ongoing chronic issues. Mom told me that she was constantly taking this child and his siblings to the hospital as well as herself. But the story goes that he started complaining of daily headaches that were worsening and worsening. He kept telling his mom he had neck pain and that sometimes his vision, instead of seeing one thing, he would see two things. And so he ends up going to his cardiologist, who sends him to neurosurgery for suspected CSF leak. And so here we actually have his images where we could see there's a MRI of the brain showing the classic features of brain sag, meaning the CSF is around the brain and the brain is supposed to nicely float in the skull. But in this 13-year-old, because there's not enough fluid, his brain is kind of just drooping down like a wilting lily. You can actually see the cerebellar tonsils. They're supposed to end about right here, but they actually end down here. You can see this is the brainstem of the brain, responsible for a lot of important things such as sleeping and waking and hunger and breathing. It is not looking like it's supposed to look, and if you're not a radiologist, you'll have to take my word for it. Another common finding associated with intracranial hypotension, secondary to CSF leak, is going to be the MRI is going to show enhancement of the covering that keeps the CSF in close to the brain. It's going to show enhancement, indicating that there's low pressure and possibly leaking. So fortunately for this young man, he had a diagnosis that his pediatricians were familiar with and his cardiologists were familiar with could be associated with CSF leak. He had symptoms that started up, and his mom was very much into noticing what was going on with her children because of their chronic diagnosis. And so then he got to the neurosurgeon who ordered the testing. The testing ended up being very, very positive. And so he ended up going to me for further treatment. So let's review some of the common symptoms. And then there's going to be some things that I talk about that are not so common that sometimes throws people off from thinking outside the box about these patients. Now, the number one symptom that most people are going to have, and we're talking 95, 90% of patients are going to complain of a headache. And commonly what is taught is that it's a headache that gets better when laying down. But what is not commonly talked about is all these variants of headache that patients may have. For instance, pediatric patients may initially say, I'm complaining of headache, I'm complaining of headache. It gets better when I lay down. But then after a while, it may not get better when they lay down. They still have headache. Or I've had pediatric patients say, Mommy, I had a headache that used to get better when I lay down, but now I just have a headache all the time. Doesn't matter whether I get up or lay down. There's a lot of variations to the type of headaches that these patients can have. And when it's coming from the pediatric population, there's going to be a different level of communication and sophistication that they're going to tell us versus our adult patients about their headache. So here goes one. Sometimes there's not going to be a complaint of headache because there's going to be other things going on that kind of obscure the picture, like severe nausea and vomiting. While sometimes the child may not describe it as a headache like we would, they may not say my head hurts, but they may say things like, it feels funny, my head, or I just want to lay my head down, but they never say, oh, mommy, daddy, my head hurts. So the presentation in the pediatric population, as we all know as pediatric specialists who deal with these patients, it can be very different trying to needle out or figure out what's going on, depending on how the child communicates and how well the child can communicate. Other common symptoms of CSF leak and spontaneous intracranial hypotension include neck pain and stiffness, hearing changes or vision changes, dizziness or imbalance that usually is associated with a change in position but can be just intermittent and ongoing, brain fog or trouble concentrating, which how does a 3-year-old say that? They probably won't. And in fact, this patient that we're discussing right now who had the diagnosis of Marfan's was always told that he was delayed in school because of his Marfan's. But we'll come back to that in a moment. Sometimes they'll get clear fluid drainage from their nose and their ears. And so these are going to be the common symptoms, but what does a child say when they're having those symptoms? It depends. And what if the child has autism or some type of sensory processing disorder? That's another thing that we'll be talking about towards the end that can make it a little bit difficult for us as practitioners to really understand what's going on because they may process sensations differently than average people do. So here is his myelography. CT myelography is considered the gold standard of care. It is an invasive test that is going to look at, you're putting dye into the back, you're mixing it with the CSF, and it's going to outline where CSF is going from the spine, and you can actually extend it up into the brain. And so here was his pictures. This is his CT myelogram. The first thing that you see right off is that he has something called dural ectasia. Dural ectasia is also something that I use terminology as capacious because I really love that word. It means a really huge thecal sac. Instead of there being fat here and fat here, which we normally see on patients with imaging, the thecal sac actually extends and is flush with the bone and is flush with the ligaments in the back of the spine. Normally, a thecal sac is not this big, but for him, it is. The next thing we see, not only is that big thecal sac, but we're actually seeing the fluid is now draining into his peritoneal cavity. And so this is a huge CSF leak. And most patients who have this much of their CSF just spilling out into their abdomen and pelvis would not be able to talk, would not be able to function. They might even be in a coma. But here again is thinking outside the box to know that there is a spectrum and a continuum of symptoms that we must be aware of from the very mild to the most severe, which could be coma or death. But of course, he's 13, he's going to school, he's complaining of headaches, but he has all of the CSF that is just leaking out in the wrong place where it's not supposed to be. And then here at another level, we can again see just contrast. It's supposed to remain in a circle around the spinal cord, but it's just spilling out into his soft tissues. So 13-year-old diagnosis is CSF leak due to connective tissue disorder, CTD. These are the patients who are bendy, contortionists like this kid here. And so it's not surprising that we see for these children that they have a CSF leak. And so on an end note for this patient, we went on and patched him, I think only 2 times. It was a blood fibrin patch, and he actually wrote me a letter thanking me because he said, one of the things, not only is my headache gone now, but one of the things that I really appreciate, Dr. Martinez, is the fact that I can think and focus and do better in school. And everyone had always told me it was just because I had the Marfan's diagnosis, but he was actually able to communicate, write, and do so much better in school. So it's important to make the diagnosis, even when it's kind of on our top 10 things to do. Now we're going to go to our next class of patient, which is going to just be these are children. They're not diagnosed with connective tissue disorder. They're healthy throughout their life. Some of them are going to have medical procedures. Some of them are going to have injuries, but some of them are going to come in with spontaneous intracranial hypertension due to some trauma we may never know, but they definitely present with CSF leak. And so this was a interesting case of a 17-year-old girl who was status post scoliosis repair. So we knew she had scoliosis before, which is I'm demonstrating in this image. And then the goal is, even though she was a healthy child, she developed idiopathic scoliosis. We are not sure why this mechanical problem happens in the spine. She had never been diagnosed with a connective tissue disorder. Testing afterwards, she didn't have, but we knew that she had rods and nails placed to straighten her spine up. But ever since probably, she said, 3 months or so after the procedure, she started having really strange symptoms. And these symptoms went on for 3 to 4 years. She complained that of her head feeling light. She said, I wouldn't describe it as a headache. It's just my head feels light or unattached sometimes, and I'm very, very tired. She said, I can sleep for 14, 16 hours at night, and I can wake up and still feel like I never slept anything and want to take a nap throughout the day. She also complained of or was concerned about some intermittent dizziness. She was actually a bodybuilder and wanted to graduate from high school and start participating in bikini bodybuilding competitions. So she noticed that like sometimes when she was working out or practicing, she would get some intermittent dizziness. And again, even though she had her scoliosis repair 3 or 4 years prior, these were ongoing symptoms that were limiting her ability to participate in school, but she was just kind of dealing with it. So interestingly enough, they talked to her pediatrician for a long, long time, and it just so happened that she finally was sent to neurology 3, 4 years later, and the discussion of whether this could be a CSF leak came up. Now, for me, it's a no-brainer. Anytime you have instrumentation of your of your spine, there's a possibility there could be a CSF leak. And the conversation that they had with their orthopedic surgeon who did the procedure was, there's no way, this is not a CSF leak. All the nails went in like they were supposed to. Your daughter's fine. So as she came to my clinic, I said to her, well, I'm going to just try something. We're not going to do a myelogram, which is usually what we do to diagnose a leak. She couldn't get an MRI that would be helpful to us because she had all this hardware. And I said we could do a conventional myelogram and try to see where the fluid leaks out. But I have suspicion if we just do a patch in the area where you have been instrumented, we could possibly fix the leak. And so I did a CT guided multi-level blood patch. That's basically using a CT machine to place the blood into the space around the spine, the epidural space, so that this can initiate the healing process and repair tears. And when I did my CT guided procedure, I did take pictures of her spine and was not surprised to see that one of the screws, instead of going through the bone and through the pedicle into the body of the vertebral body, one actually encroached on and went through the central spinal canal. The good news is that after we did the blood patch, all of her symptoms resolved and she's doing good almost a year later. And so sometimes I put this slide in to say 90 to 95% of the time for me, when it comes to a pediatric population who may not communicate, but their parents are very attentive and knowing their child's behavioral differences, it's not the MRI, it's not the myelogram, it's actually the diagnosis comes from the patient's story. So, for all of us healthcare providers out there, if we literally just take the time to let them tell you everything, there will be common repeat symptoms that the child is having that the parent notices that points you into the direction of a CSF leak. And sometimes you'll have some clues from the medical record, but 90 to 95% of the time, the diagnosis is going to be based on the clinical history. No imaging needed. And so this is a case of a patient who underwent an iatrogenic procedure, underwent a procedure, had an iatrogenic trauma injury, and developed a CSF leak. And this is, again, commonly what the pediatric population is thought to have CSF leak from. But even in this scenario, even though we knew there was instrumentation, and because her presentation was a little bit different from the classic, I have headache, I need to lay down, the story that she told kept her from getting to the right people for 3 to 4 years after her scoliosis surgery. And so, again, thinking outside the box for these disorders, but finding the common patterns is very important. And so here I put this slide where we have Pegasus. If you ever hear a CSF pressure talk from me, I'm always talking about Pegasus because Pegasus is a mythical creature. And I like to dispel the myths of CSF pressure disorders, especially when it comes to CSF leaks. Now, there's oftentimes that parents will say, my child has this leakage from their nose, and it's not blood, or it's watery blood, or it's not snot, or it's very watery snot, and it happens first thing in the morning, or sometimes when they go to bend over, and sometimes my kid tells me there's like this fluid coming from their ear, and the doctors may pick up on this, especially if the child is saying they have headache, and order a beta 2 transferrin test. But believe it or not, this has low sensitivity for CSF leak unless you have a copious amount of CSF. And if you look at the history of how beta 2 transferrin testing came about, you will find that it was actually for post-iatrogenic procedures where they knew there was a tear in the dura and the connection in the body was very easily accessible and the beta 2 transferrin test could be done. But when you start intermixing it with blood or cerumen or mucus, snot, for the lack of a better word, these tests are not all they're made out to be with all the sensitivity that we have depended for them to be on. And so I advise those who suspect they have leak to insist, I still think there's something going on, even when the beta 2 transferrin test comes back negative. All right, we're almost done and we're getting close to the end. But this is, again, a story of a lifetime, a story that I'm so glad that I got to be on the journey with the family and the parents for this girl who probably would have ended up being one of my adult patients in the future if we wouldn't have been introduced by accident when she was 16. So the story goes, healthy 16-year-old girl, teenage girl, cheerleader. No medical problems except she was diagnosed with congenital scoliosis when she was young, but that didn't keep her from being super active and super busy. As she was going to the top of the pyramid during cheerleading, she experienced a sudden pop in her back and sudden onset pain. Seconds after, she couldn't move her arms and she couldn't move her legs. It was scary. All her cheerleader friends quickly took her down from the pyramid. Her mom was called, her mom was there. They rushed her to the emergency room. By the time she got there, all of her symptoms had resolved. When the neurologist evaluated her in the emergency room, she was fine. There was no neurological deficits, no problems. So they had no clue why this happened. They shipped her out. She felt comfortable leaving because she felt much better and her pain had improved in her back. She goes back to cheerleading probably a week later, and this time she experiences a pop in her neck. Same sort of situation, pain, inability to move her upper extremities and her lower extremities, but this time, instead of rushing to the emergency room because she got better before, they didn't go. But she started complaining to her mom and dad of headaches. But they also noticed that she had these episodes, and that's what they called them, where she couldn't talk, she couldn't move, and then she would suddenly lose consciousness. When she woke back up, there was no confusion. She never wet herself, but they would literally see her wink out, and they kept saying her headaches were getting worse and these episodes were getting worse. When she goes finally to the hospital because it keeps happening and it's not going away and it's not getting better, she's transferred to our hospital where she has a 3-night stay, every imaging possible in the book. And in the end, they decided because she had a history of anxiety and she was a super duper achiever that she needed cognitive behavioral therapy because this likely was secondary to her underlying anxiety. We met by chance because some of the imaging showed an incidental finding that turned out to be a normal variant. But while I was talking to her, she kept passing out and she looked very pale and she was slumped over in the chair and she looked very uncomfortable. So I told her, "Have you ever tried to lay flat?" And she said, "No. I mean, I go to bed, but I never do that when I'm having these episodes." And so I said, "Let's just try to lay you flat for 5 minutes and see how you do." Immediately, she started noticing that her headache improved significantly. And she said, "I just actually feel better just by lying down." But this was all covered up because they just knew that the fact that sometimes she couldn't move her arms and her legs and other neurological symptoms that were happening, it was obscuring if she felt better when she laid down. It was obscuring the fact that she even had a headache. We went on to do the CT myelogram and we found that not only with her congenital stenosis, she had multiple areas where she was leaking CSF in the cervical, thoracic, and lumbar spine. So what do we do when a patient has multiple CSF leaks or CSF leaks? The first thing we're going to do for treatment-wise is make the patient lay flat. That actually helps them a lot. Your pressure is going to be higher when you're laying flat than when you're standing up because gravity lowers pressure. We're going to tell the patient to hydrate. We're going to tell the patient to take some type of pain reliever. Anti-inflammatories can be very helpful in this scenario. And then if all of these things are not really working for the patient, and I forgot to put in caffeine, we actually don't know why caffeine helps, but we do recommend caffeine pills or sodas or teas. We go for something a little bit more invasive, and that's basically using a needle to place blood into the space around the spinal cord in order to initiate the inflammatory response and seal and heal up leaks. And so you can get a blood patch, you can get a fibrin patch. If these things fail, then you can get a surgical repair. So for this young lady, we actually did multiple blood patches. She would get better. her losing consciousness episodes would improve, and then she would get more active. She would start getting back to school and not being in bed. And then she would go right back into the same state where she started experiencing headache and started having these passing out episodes. This repeated itself about 4 to 5 times. And each time, what I noticed was that it seemed to be that the leak was in a different place. Now, we didn't do the myelogram every time, but we did note that when we did do a second and a third myelogram, um, the leaks had went to a different area of her spine that we hadn't patched before. And so we started thinking outside the box, but also it came from my experience with my patients at my prior institution when I was a fellow. And we started thinking that this patient may be suffering from something else. We call this the popping of the balloon. This is when you really have underlying idiopathic intracranial hypertension, but you have intermittent CSF leaks that spills out the CSF fluid that you have too much of. The leaks then seal off. Your body overproduces more fluid to compensate for the leaks that were occurring. And that increases your CSF production, which causes you to go into a higher pressure. And then your balloon begins to fill again and then pops again. This leads to a vicious cycle of I'm high pressure, I go too high, especially if I exert myself, have a difficult bowel movement. These are some of the stories that, parents tell me. I start getting back up and running around outside and going to play. And then I leak. I want to lay down. I'm super fatigued. I have a headache when I get up. And I go to lay down and start sealing off those leaks by laying flat. And then I'm right back in this vicious cycle again. Now, I have termed this cyclers, and this is a very, very, very important diagnosis for the adult population, and it's definitely in the pediatric population, because these patients can present in a different state depending on the time of the day, the time of the week, or the month that you see them. So sometimes they'll come in saying, I just want to be in bed all the time. I can't get up. My head hurts. But then there'll be times where they say, but if I lay too flat, I have to sit up because then I start hearing ringing in my ears or some other high pressure symptom. And these patients will just cycle back and forth. Their imaging also can have mixed features of high pressure and low pressure, or be totally normal because it's kind of like a balancing out act. And so with that patient, we ended up having to treat her high pressure so she couldn't continue to leak every time she exerted herself or Valsalva, which would cause an immediate spike in her pressure and then cause her to leak. So that's my 3 patients categorized in the pediatric population that we have to watch out for. Those with connective tissue disorder are a little bit easier to identify. Those who may present iatrogenic or trauma, again, easy to identify. Those who present with some type of spontaneous intracranial hypertension, no past medical history, but do give you signs and symptoms that they're having a leak. Pay attention for them because sometimes they can get away. And then last, the patient who really has underlying idiopathic intracranial hypertension, but intermittently leaks, so the picture is all obscured. These are the patients that present with episodes, dysautonomia that's severe, involving their heart with arrhythmias that come and go. Nothing is constant. Sometimes they're better, sometimes they're worse. Think outside the box. They may be a person who cycles between high and low pressure, and it doesn't matter their age because I've seen patients as young as 3, 5, and 6 suffering from this. But in the end, again, anyone can suffer from a CSF leak. And I am here to be a resource, to review imaging, to help parents understand these different phenomenons, to come up with treatment plans and treat the children if need be. Thank you so much for your time. I look forward to your questions.
Thank you so much for that excellent talk. It was fantastic and very informative. We have a few questions, and just to remind those who are attended, yeah, you can feel free to post your questions on the Q&A board. I think we just have enough time. So the first question is, what do you recommend for a caffeine limit for pediatric patients?
I don't have a limit. For me, they are high metabolizers and everything kind of percolates through their system more than adults do. And again, I have to preface this that I have an adult population of patients and a pediatric population of patients. And so I just told mom and dad that, hey, if you want to give them a soda, a Mountain Dew, one in the morning, one in the evening, go for it. This is the first time. In fact, some of my younger patients love me because their parents don't allow them to have soda. And I say, Dr. Martinez is telling your mommy and daddy to allow you to have soda twice a day. And one little girl, I remember her specifically, she stood up and just hugged me because she thought that was the most exciting thing she had ever been told at a doctor's appointment. So I don't give a number. I just tell them to allow them to drink tea, allow them to drink soda. Um, and I don't give a number or a caffeine pill. Usually we just do it with natural elements with caffeine in them.
Thank you. The next couple of questions about your group of idiopathic intracranial hypertension group, the cyclists. How do you treat these patients?
Yes.
And then one delegate also mentioned stenting experience in
Yes.
pediatrics.
Yes.
If you can comment on that, please.
Yes. So I consider myself the leading stenting pediatric neurointerventionalist in the country of the United States for the pediatric population. My paper should be coming out at the end of this month, early next year. I have a cohort of over 20 children who have underwent dural sinus stenting for idiopathic intracranial hypertension. In fact, that 16-year-old patient, she underwent stenting, and she's now 19. She's writing her case report with us. She's off to college. She hasn't had any more symptoms of CSF leak. Um, and it went, in my experience, the stenting goes very well. But before you go to the mechanical anatomic changes, there are things that we usually try to do to break the cycle of the CSF production, up regulation in CSF production. And that's going to be by some lifestyle changes like sleeping with pillows at night, introducing gravity into the equation, increasing activity to the equation to help with CSF flow, which goes through the venous system, and circulatory functioning is dependent on all of this. So increasing activity, increasing movement are some natural things you can do. Another thing that I'm doing with patients, adult, peds too, lymphatic massages, believe it or not, are related to this whole scenario where if you go for a lymphatic massage, it actually has been seen to decrease headaches anecdotally in different patients, but it actually has been many different patients in many different states around the United States. Um, we also will put children on medications. We don't like to, but good old Diamox, acetazolamide, or methazolamide, which sometimes can be a little bit easier on the system, or Topamax, which a lot of parents do not like because there's such a bad side effect profile, but it helps with headaches and it helps with lowering pressure and CSF production. So you have your acetazolamides, topiramate, and methazolamides, medications to lower pressure. And the idea is if we can slow down the production of CSF, most children will, in 3 to 6 months, auto-regulate their CSF production and actually get back into, I'm not overproducing, I'm not leaking, and that vicious cycle. Now, as you start hitting puberty, what I've noticed is That cycle is vicious and harder to break. And when you get into adulthood, it's even harder. And so it is only the severe cases where the veins, and I mentioned this before, the veins are responsible for draining CSF from your brain. And that's going to be the veins inside your skull, your brain, around your brain and your head, the veins in your neck, and those are going to go back towards the heart. And so if you have veins that are collapsed or narrowed, that can actually cause the CSF to build up and not be able to drain. VP shunting is another way to treat idiopathic intracranial hypertension. That's placing a small catheter through the skull into the brain to drain that fluid off. That's too much of it. And that's going to be a treatment that's been the standard of care for many, many years now for kids with intracranial hypertension. But I do encourage neurologists and neurosurgeons to make sure if we're thinking about VP shunting, we consider dural sinus stenting because there are children who fall into that category where it's just they're not draining through their veins. And instead of bypassing the veins, maybe we can open the veins with a stent. The last one that I've gotten pretty savvy of in the last year is actually giving blood thinners to patients who have internal jugular or intracranial venous stenoses. The idea is now we're making your blood flow again better through these veins because instead of being syrup consistency, it is now water consistency. And we've actually seen patients started on anticoagulation, Plavix, their symptoms improve because now the blood can flow through the veins better and the CSF can drain through the veins better. So these are all things that we're looking at in order to help children with idiopathic intracranial hypertension.
Thank you. We're getting a lot of feedback here with really a lot of appreciation, but I'm also aware that we're running out of time a little bit. But this question comes all the way from Calgary, from one of the neurologists, is an adult neurologist, and he says, asking about some of the key differences in the presentation of kids and adults. Maybe, I suppose, if I can add on to this, if you can comment on the key, I suppose, clinical symptom differences and maybe the neurological finding difference, if I may ask. Yeah.
You know, the headache type may be different, but I don't think it's so much because the headache is different in the adult patient than the child. I think it's more that the child has a hard time describing and communicating like an adult would. When I feel better, I lay down. When I lay down, I feel better. Or when I get up, I feel worse. What you'll find is children will just, some of them who are nonverbal will just grab their head. And their parents are very in tune with, okay, that means they're having pain. Or they'll just lay down and not have much activity. And I'm talking about on the lower, the younger scale of things for patients who have not hit puberty, who are early toddler. They're able to communicate somewhat, but not completely. When you start getting into the puberty age, young teenagers, young adults, the symptoms are very similar. The only time that I see that the symptoms for classic spontaneous intracranial hypertension differ and the presentation is when they have this underlying idiopathic intracranial hypertension driving their leaking. And then that's a whole 1 hour talk that I would love to give. Just send me an email because the neurological changes that occur, first of all, they're systematic. The headache can be easily obscured by the dysautonomia, by the brain fog, by the psychiatric symptoms. There's something about this intermittent, I'm high pressure, then I go into low pressure that the body doesn't like, and it really scrambles the brain. So you can even start having stroke-like symptoms, which I'm a stroke expert because I do thrombectomy and the whole gamut. But patients will come in with stroke-like symptoms that go away and are not seen on physical exam because they shift it from high pressure to low pressure or vice versa. And they had this blip of symptoms, and it can make it very hard to diagnose. So I would say, symptomatology wise, when it comes to just straight up CSF leaks, it's the lack of communication or the ability to express This is when it hurts. This is how much it hurts. This is what helps get it better. And parents really become our lifeline because they're going to be telling you, my children are not playing like they used to, or they were just in their room. I know one kid, he hated telling he had a headache because he knew he'd have to go to the hospital. So he'd just go in his room and lay down and sleep after school. He wouldn't say, I have a headache or anything. He didn't want anyone to know. But yeah, the symptomatology for classic CSF leak, they're pretty similar.
One other question, just before we close, if we have time, is do any patients, pediatric patients, usually have MCAS, MCAS? And if so, does that raise ICP?
That is a wonderful question, and I'm glad. I'm going to try to be quick. My basis behind idiopathic intracranial hypertension in pediatric patients, I believe it's secondary to chronic inflammation, infection, autoimmune disorders. Because the glymphatic we know now exist, I believe those kids who are exposed to infections or have MCAS, which is an inflammatory response of the body to some type of external agent, they increase their CSF production in response to this hyper inflammatory, infectious, I need my lymph system to respond. So just like the body, the lymphatic system will upregulate in response to cancer, foreign bodies, microorganisms. I feel like the brain does so too by the way of increased CSF production. And so children who have MCAS, to me, that tells me you likely are hyper responsive to your environment. And then that can set you up for this dysregulation of over CSF production, which can lead to headaches because you have IAH or you have atypical features of IAH because you leak as well. We also know there's an association of MCAS and its impact on connective tissue. And those with fragile connective tissue can leak. So when you start putting all these diagnoses together, yes, there is one umbrella. And I believe I'm not confused about the chicken or the egg no more. I think neuroinflammation is the egg that leads to the chicken of idiopathic intracranial hypertension, at least in this cohort of patients, pediatric patients, not obese, not 40s, not, fertile, blah, blah, blah. And then that can explain bringing in the MCAS diagnosis. I hope that helps.
Okay, I think that's it. Thank you so much once again, Dr. Martinez,
Thank
and it was
you.
a fantastic and informative session. And again, thank you, Bahari, for making this session possible.
Yes. Thank
Well,
you.
thank you to both of you. It was a wonderful talk, and I really enjoyed listening to you, and it was very insightful. And thank you again, Dr. Kim, for moderating the session for us. And I'm looking forward to your next presentation.
Oh, thank you so, so much.
Have
It's
it.
such a pleasure.
Thank you. Have a great evening, and thank you, everyone, for joining.
Thank you, everyone.
Bye.
Bye.
Bye.